has been speculation that the percentage of patients with portal pulmonary hypertension may have decreased over time. And indeed, that was the primary finding of this study. My name is Charles Berger. I am the medical director of the Pulmonary Hypertension Center at Mayo Clinic in Florida and a professor of medicine in the Department of Internal Medicine. The manuscript is entitled Echocardiography Screening of Consecutive Patients with Portal Hypertension Referred to Mayo Clinic for Liver Transplantation Evaluation, and will be published in an upcoming edition of Mayo Clinic Proceedings. The investigation really centered on the utility of screening echocardiography in patients referred for evaluation for potential eligibility of liver transplantation, looking for a very serious condition that's a known complication of liver disease, and that is portal pulmonary hypertension. It's a condition where the pulmonary vessels have narrowed and resistance to blood flow through the lung circulation is increased, therefore engendering a raise in the right ventricular pressure and pulmonary artery pressure to overcome that resistance. This is very hazardous in the setting of consideration for liver transplantation, because once the diseased liver is removed from a patient and the donor liver is implanted and the blood volume is recirculated, if a patient has significant portal pulmonary hypertension, the right heart may fail and the patient may not survive the procedure. So it's important to detect this, and it's typically done by estimating right ventricular systolic pressure using echocardiography in all patients that are referred for liver transplantation. And if the pressure is elevated, further evaluation with right heart catheterization characterizes whether it is indeed secondary to the liver disease. This is done routinely in all liver transplant centers, and previous literature, although much of it is in excess of 10 years old, has indicated that the presence of portal pulmonary hypertension in these patients may be as high as 9%. However, in our study of over 900 patients, was found to be less than 1%, so a significant difference. Mayo shares its liver transplant program, indeed its solid organ transplant program, across all 3 destination medical center sites located in 3 geographically different areas of the country: Arizona, Minnesota, and Florida. This may provide a clinical cohort that's more reflective of the practice in the United States than that might be performed in a single center from a single location. The clinical protocol for diagnostic evaluation of these patients is shared by all 3 of these sites. So there's consistency in that evaluation. We know that the right ventricular systolic pressure threshold by echocardiography has changed or evolved to some degree over the years, with varying thresholds suggested. The pressure threshold that Mayo Clinic has been using of 50 millimeters of mercury, however, may be a bit high based on the result of this study. We're suggesting consideration of lowering that threshold to 45 millimeters of mercury, which seemed to represent a better cutoff value in the cohort that was analyzed. There may be a lower percentage of portal pulmonary hypertension in end-stage liver disease in patients that have portal hypertension from the end-stage liver disease, and patients with end-stage liver disease, portal hypertension, that are referred for liver transplantation. So 3 provisos than has been previously demonstrated in the current literature. As mentioned before, that has been as high as 9%, and our study was less than 1%. And if that's true, that's good for patients, because portal pulmonary hypertension, if not successfully treated, may create a situation where the patient is ineligible for liver transplantation. The second is the opportunity to refine the right ventricular systolic pressure threshold and introduce a more appropriate level of 45 millimeters of mercury as opposed to 50 millimeters of mercury that has been used historically. As mentioned before, perhaps there has been a change in the number of patients that develop this serious complication from liver transplantation. And if that's true, that's good for patients. We've speculated that certainly there has been some evolution in the cause of end-stage liver disease over time, with a higher prevalence of metabolic syndrome-associated steatohepatitis. That may indeed translate into a reduced risk factor for portal pulmonary hypertension. This is purely speculation. It's not known if that's true. And quite frankly, the reasons for our lower percentage are unclear and will require further clarification going forward. In addition, we certainly appreciate the fact that treatment for pulmonary hypertension with pulmonary hypertension specific medication is more widely available than it ever has been. And it's possible that patients are treated in their local communities with the availability of these medications, and that either delays or discourages referral to a transplant center. We are blessed with this system-wide data cohort with a consistent approach to the clinical evaluation of patients. And we want to leverage that same cohort and findings from this study, including outcomes around percentage of patients who actually had liver transplantation over a 2-year time frame and survival, with a relatively recently developed machine learning artificial intelligence model layered onto the discrete data and findings from echocardiography that may identify new patterns that enhance the sensitivity and specificity of screening echocardiography for portal pulmonary hypertension in patients referred for liver transplantation. So that has not been done, but is planned. The model has been used on other cohorts. So we will move forward with exploring whether or not that model might be applicable to end-stage liver disease patients with portal hypertension in whom we screen for portal pulmonary hypertension. It's been a pleasure sharing the findings of our manuscript. I would like to invite you to thoroughly review that article for more details and any feedback that you might have regarding your impression of the clinical results from that study.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.